Hi, everyone. Welcome to the Para Podcast Show. I'm Elias Thomas. I am your host, and I am joined by Malusi Mtetwa, who's in Australia. And we also have Tulani Sibanda, who is in the Middle East. And we are joined by our guest today. He doesn't want to be called Dr. Soman, but he wants to be called Soman. He is at least he lives in Zimbabwe and he has been practicing and doing some work in Zimbabwe. Since we wanted to know a little bit about what's going on EMS in Zimbabwe, we decided to confront him. I think, few loopholes. We managed to get through to him. Saman, welcome to the show. And thank you for being here.
Thank you, Elias, for inviting me. Thank you, Malusi, the co-host, and Mr. Tulani. Thank you so much for. It seems like you are the tech guy behind all this thing. Thank you so much for setting it up. It's my single honor and privilege just to be here to speak to you guys, and I hope we will achieve what we set out, broadly speaking, to create an awareness of what's happening with regards to EMS activities in Zimbabwe, maybe, comparing with the international best practices, where are we and what's happening, what has been happening since time immemorial. And I'm happy to be here to share a little bit of that.
Okay. Yeah. No. Thank you. And I say this in all honesty and humbleness, but we know nothing about EMS in Zimbabwe. I know a little bit from South Africa because I had a lot of interactions with them. I just recently got to learn of what's happening in Botswana. I mean, Namibia, that's where I'm from, so I kind of know the system in and out, to be very honest, but nothing about Zimbabwe. So I thought, let's get someone from Zimbabwe. And as I was scrolling through the internet, I saw one of your papers that you published. So I just wanna, let the listeners know who's Dr. Soman. Who are you? What's your background? And yeah.
Okay, thank you, Elias, for that first shot. It takes me back several years in terms of how to describe who Soman is. I'm 45 years old, and I'm Zimbabwean. I was born in a small town called Marondera, though I then grew up as a village boy in Chiweshe, herding cattle, goats, plowing, working the fields. My father, self-employed in the upholstery industry, does a little bit of making and manufacturing of sofas, repairing, but I didn't want to have any of that. They would call me lazy when I was working in the fields. They call me lazy when I was, trying to imitate my father. So I vowed to take a different path. So I chose medical. Initially, I wanted to be a pharmacist. When I was doing my fourth form. But when I went for A-level, my mother had a maternity emergency when I was doing my sixth form. So when I visited here from the boarding school, the Canadian doctor was working there asked me, so if you are doing science subjects and you don't want to be a doctor, who is going to be treating your people if I go back to Canada? You can't all be relying on expatriates visiting you, yet you want to do pharmacy. The respect to pharmacy, but why don't you just bite the bullet and go for medicine? So I felt challenged. When you're talking to a Caucasian from Canada, they make things look appealing, and you think maybe because your mother is lying there fighting for her life, you are probably coerced into accepting something like that. So they decided to join the industry. So I've been practicing for 18 years now. I graduated in 2005. I got married in 2006 because I wanted to settle down very fast and focus on other things. A settled medical doctor will probably achieve results better than someone who wanders around. So I got married in 2006. I'm blessed with 3 children, 18, 14, and 6. And the factory is closed now. So, my wife is a physiotherapist. She did orthopedic physiotherapy at Wits University in South Africa. She's currently a clubfoot consultant with Miracle Fit. Currently, I worked for City of Harare from 2010, then decided to move to head the EMS, the ambulance division. So the ambulance services there, at that point, there was no medical doctor heading the division. So I always want to do things differently. City of Harare is more of public health issues, TB, HIV, and primary health care. There was no one interested in moving towards the EMS. Having had the experience to be in a district hospital, be a master of all trades, jack of all trades, where you attend to emergencies, where you rush to collect victims by the roadside after an accident, where you rush to collect pregnant mothers who are in labor and they need medical intervention. You kind of get a picture of where you want to be. Because I was now surrounded with a lot of public health specialists in City of Harare, I felt I would make a difference in the pre-hospital emergency care in the EMS. So I just went for the jugular and that's it. And I was with EMS for about 12 years until I called it quits in 2022. But it has been quite an amazing time. I enjoyed it and I still enjoy it now. And I believe I'm still, if I'm to do it again, it will be in EMS and the pre-hospital emergency care.
Okay, that's quite a journey, isn't it? And I'm sure we could, cut into pieces few of them to try and explore it. But let's discuss the EMS when you got into City of Harare. What was the system like? When you walked in there, was it sort of like a privately run service where you only respond to people that are of a specific background, or did you cater to everyone else? That if you needed an ambulance, you send an ambulance, or was there an ambulance, if anything, really?
Okay. No, if we are to understand the background, I think that's a fair point to begin with. So I will describe the EMS system in Zimbabwe. It's actually well developed, and you can divide it into 4 government hospital-based EMS systems: council-run local authority EMS systems, mission hospitals, EMS systems, then private EMS providers. So the government one are simply hospital based. The ambulance system they are dispatched to collect patients within the communities, then back to the hospital. Or if it's a district hospital, this is where the ambulance gets activated and is dispatched to convey either pregnant woman in labor who could not deliver from a clinic 10 to 20 kilometers away. Then they are conveyed back to the district hospital where they have an improved capability in terms of dealing with the maternity emergency. If they can deal with that, then the mother delivers there. If not, they then transfer or convey the patient in labor to a secondary level care or to a provincial hospital where they expect the services to be able to meet the demands of that particular patient. If they can meet the demand, or if they can respond and deliver this patient, they'll do that there. If not, they will then convey to the tertiary, which is the central hospitals based in Harare or Blaue. So the private EMS ones, these naturally they are very appealing, they are well run, and they look savvy and they're attractive, but they're expensive. Very few people can access them because they are paid out of pocket. Or you can use your medical insurance to access them. So this is where you call them. They part of their initial triage when you are generating that response. You'll have to be asked, how are you paying? So you then say by cash or by medical insurance. So it's for those that are well-to-do, those that have the resources to pay out of pocket, or those that are well covered by medical insurance. They work perfectly well, and they're also very efficient. But for those that are above a certain pay grade, for those that can't afford, they will not access services through the private EMS. Not a photo of their own. The main health structure should have mechanisms for any EMS facility to respond to anyone, but they should get their payment from, a centralized health fund of some sort. Because they're in it for business, and you have to be fair enough. Then the local authority where I was based, for me, that's where I am. I get my heart beat faster, because that's where you can tell you're helping people who are relying solely on you. But the challenge is we had few appliances or ambulances for the whole city of Harare. It's got a population of 3 million. So in 1984, now I'm going back historically, in 1984, that's when the EMS system for city of Harare started.
Before we're all born here.
I was 4 years old then.
Okay, we were not there, all of us.
So because City of Harare provides other emergency services, we're talking of fire brigade. So the EMS system for City of Harare is a fire-based ambulance system. So there's a chief fire officer overall in charge, who is followed by a medical doctor who looks after the ambulance, the EMS side, and also does part of occupational health services and or emergency in-house emergency preparedness issues. So basically, you're in charge of making sure that your ambulances are ready to be dispatched. You also should be leading on site or off site. You're also supposed to be reviewing protocols to see if they still speak to the population that you intend to service. You also want to then review and do a critical analysis of what are you doing, because you may have several vehicles or ambulances, but on the ground you're actually doing nothing. You're not impacting positively because you're not able to critique the way you're responding. If any gaps, or if you are achieving what you set out to achieve, or if your pre-hospital emergency outcomes are positive, because that's why we are there in that greatest hour of need, where there's no doctor. You need someone to stabilize you, then convey you to where you get definitive care. So there are outcomes that are specific to pre-hospital emergency care. So you then look critically at those outcomes, if ever you're recording them, because you have to record them first to be able to look back at them and see if you're improving, or if you're not improving, or if you're actually going the other direction. So from 1984, it was a fire-based EMS. Then 10 years later, it became very professional. Professional, I mean, where we had ambulance technician as the entry point qualification. Then you progress to emergency medical technician, and it was like that for a long time, until I then joined in 2011, 2012. So it was very professionally run. The capabilities, they range from basic life support to advanced life support. And we also have a training school where we're responsible for training anyone within City of Harare or outside City of Harare. So I'll tell you a funny story where in 19 1996, there were over 47 ambulances only for city of Harare. Their daily calls were 300 per day. So the private sector really struggled to compete and complement city of Harare because each district within the city was well covered. There are like 40 districts in the city of Harare. So basically each district had a dedicated ambulance for that district. So whenever a call comes, it will the first responders or the EMS would come to assist. Will be from city of Harare. The other advantage is we didn't demand out of pocket or cash or whatever. We would just, it's like a South African system where you call out for help, and instead of paying cash, that bill gets charged to your residential bill, water or whatever. So you don't need to pay cash for city of Harare or city of Bulawayo EMS services. So that's how, if the ambulances were there, no other private provider would compete or complement at the same level, because the ambulance will simply be will do the job well. The residents don't pay cash. So it's like your first port of call. The challenge is then developed during the downturn of our economy, and we had challenges with our fleet replacement policies and also other challenges that we were basically out of our control. Our fleet started to decline. So by 2012, when I joined, there were about 5 ambulances for the whole city.
From 43? Yeah.
From 43 to 5.
What happened?
So, economy.
10-year period. 10-year period. But how do you lose 41 ambulances?
So that's what I've attributed to issues within the city and the global picture for the whole economy. As a country, we went through a difficult time. We struggled when we started to, try to have a redistribution of resources within our country between the people that are considered as minority and the people that are considered as majority. So that came with, of course, a backlash in terms of economy. We couldn't access international loans. We couldn't, proceed as what was happening before. For example, I think it's normal politics that when you don't do what is expected of you as a weaker nation, you get punished for trying to set things into your favor. I know even Donald Trump is withdrawn the HIV gay funds in South Africa.
USA, yeah.
So you are trying to do what's right for you as a country, but someone who has been giving you freebies is not the freedom to withdraw in terms of trying to make you, toe the line. So for us as Zimbabweans, we suffered during that period of land redistribution under our late president. So it affected a lot of things. But that is not the only reason why we suffered. We suffered because maybe we didn't have the right policies to finance our own, medical systems, specifically pre-hospital emergency care. We didn't have a vibrant, reproducible fleet replacement policy, because we used to replace our ambulances every 5 years, 3 to 5 years. The ambulance will be replaced. The old ones, that's how we managed to accumulate. So the old ones will just accumulate, and we increase the number of our workforce, and also we improve our response times, and we also reduce the waiting periods. But when you have so many problems, you start to lose, you start from failing to repair, to service, then to failing to buy. So there are, of course, factors that we can control and factors that were within our control that we didn't do well. So if you are to develop as an EMS system, you should be able to critically admit where you did gaps, challenges, and where you think you would have improved.
Yeah. Can we go back a bit? You've said
to unpack there.
A mouthful. It's a whole lot. Okay. Firstly, what I discovered as you're talking, what I learned actually, is that you have 4 types of ambulance systems. You have the private, you have the government, you've got the missionary, and you've got the council, right? So all of these, they function. And I understand the private is funded by the private sector. The council, is it somehow funded by the government and the council, or is just the council by the people that live in that region?
So initially, local authorities, they're an extension of mainstream government. So they are called local government authorities. Yes. So you can't separate the two really if things are to function very well. So obviously there will be funding coming from the national budget. Then, as you remember, local authorities, they are not a profit-making entity. They are there to provide services to the people, provide water, collect refuse, provide other, things that are deemed social services, medical services, administrative services, all those things. But obviously, we collect, the local authorities collect revenue from residents, and part of that revenue is then used to finance services, be it medical, be it pre-hospital, be it fire. So, coming to your question, local authorities funding can be binary, but recently it has been skewed towards a local authority largely funded activity as an EMS entity.
And who are the missionaries? Where are they from?
I said military, peacekeeping.
Oh, you said military?
No, okay. I'm thinking, I don't know.
Mission hospitals.
Mission hospital, yeah.
Mission hospitals.
Is it, how does that work? Is it like from the olden days they came and they migrated to Zimbabwe and they just stayed? Is it that or something else?
So the mission hospitals that are running EMS systems, these are the ones that founded hospitals as part of their missionary work. Some established schools, and on top of schools, they established hospitals. But for them to convey their patients, they then developed their own ambulance services or systems. They didn't have to rely on government units to move between their hospitals and the centers of definitive care. So these are people who came to Zimbabwe way back and developed, constructed hospitals, schools. So they also then saw the need to add ambulances to their, framework, to their operational framework. So they are recognized as ambulance from the, mission hospitals. They also convey patients to government hospitals, central hospitals or provincial hospitals.
And who funds them?
Hospitals are obviously well run, they're well supported, and they're doing well.
Who funds the mission hospitals?
Yeah, no, go ahead.
I was saying who funds?
They've got their own separate way of getting funded. So if it's a Catholic church, it's probably funded from maybe all the way from process from the Vatican or from the local congregates, or the funding in that area is complex. I may not know what exactly goes on there, but naturally, if it's a Catholic church, obviously it's connected all the way to the Vatican, and if it's a Methodist hospital, they have got their own ways of funding their medical activities. If it's a Protestant hospital, a church hospital, they have their own way of funding. But what is obviously apparent is they then also employ people, doctors, nurses, who are either trained locally or who come in as an expatriate from outside.
Okay.
Tumani, I think you had a question.
Doctor, what I want to ask before I ask my question, when you're in South Africa, where did you go? Where did you stay? Well, where did you visit?
A lot of places.
Were you in Joburg, for example? Because my question is based on the question that I want to ask you is basically similar to Joburg.
Joburg, I stayed for a month in Fourways. Then I visited my in-laws in Lenasia Park, a place called Zakaria Park.
Zakaria Park. Okay. So I think I'm trying to understand you mentioned the mission, not the mission, sorry, the hospital government based and the local authority emergency medical services. I think my understanding of it's something that we sort of have had in South Africa, still exists. But how I can explain it is that in Joburg, you had the government emergency medical services, which is the provincial Gauteng EMS, which is overarching provincial emergency medical services. And I'd assume maybe in Zimbabwe, in Harare, that would be your hospital government based because they cover a wide area. And then we've got also within Joburg, we had the City of Joburg Emergency Medical Services, which was a component of broader of emergency medical services of Gauteng Emergency Medical Services, which provided services to different municipalities around City of Johannesburg. But also, if you look at, I don't know if you've been to Pretoria, in Pretoria, they also have City of Tshwane, which was also a fire-based. City of Joburg is also a fire-based EMS service. Pretoria also was City of Tshwane, which was a fire-based emergency medical services, which provided fire services together with ambulance services. And then you had government emergency medical services, which oversees the City of Tshwane and City of Joburg emergency medical services. But also there was that coordination and integration of emergency medical services between the government and the municipalities to a point whereby I'm not sure when they took over, but the Gauteng Emergency Medical Services eventually took over the whole of Gauteng, where they provided a broader aspect of emergency medical services in South Africa. I don't know. Does that look similar to what I'm explaining to you in Zim in terms of the hospital and local authority EMS?
So when I was doing my MSc in emergency medicine at WITS, 2014, we got a week where we were made to understand the broader perspective of how the EMS pre-hospital emergency care is run in South Africa. So what you've just said is very correct. Is what we have been told. Unlike in Zim, the EMS services is actually the prerogative of local authorities. If it's Harare, the EMS services are provided largely by the local authority. So City of Bulawayo has its own EMS service provider, which is the fire-based, based within the City of Bulawayo. The City of Mutare, each city has got its own EMS. So which is like a provincial EMS, what you have just alluded to, like Johannesburg and Tshwane, they would separate EMS services that are run in different layers, either local authority that are fire-based or that are also superintended by a government EMS system. That is also very important to make sure that all the EMS activities are synchronized and they function in a seamless manner. But the challenge in the gaps that we see with our structure, where in the mainstream Ministry of Health, there is no directorship of EMS within the Ministry of Health structure. You have director of HIV, director of other services, TB, whatever, but you don't have a director who's overarching all the EMS activities within the country, because that would make a structure where the provincial or the district EMS activities will be under the provincial under the national. Then the private players will also come under the auspice of the broader EMS activities be it at local authority or at national level. So I've heard that they are trying to restructure and introduce EMS people for ground services, for air services, and also a main director who is in charge of those two things within the government structure. But that is not taken off as yet.
I had a last one, Elias. Do you have a council for healthcare providers that looks
Yes.
after paramedics? So if you're a paramedic, you register there.
So, like I said, it's professionally run. So all the EMS service providers, they are registered what you call the Allied Health Services of Zimbabwe. So allied, it means it's not specific only to EMS people. You know, anyone who is allied to medical services, considered allied to medical services. We're talking of your dietitians, nutritionists, dental
Radiographers.
technicians. They are all clumped under allied. But there's movements and lobbying. I've been one of the proponents of people who were lobbying to create a specific EMS council that speaks only to pre-hospital practitioners.
And how important is that to have a specific? I know for in South Africa, why is it important? But from your perspective, how is it important to be separated from being allied, to have your own professional identity as a pre-hospital? In SA, we call it the Professional Board of Emergency Medical Care, which encompasses all the emergency care providers in South Africa, from the lowest qualification to your advanced life support.
It's quite salient, and in the fact that when we started this podcast today, I spoke of EMS as a specialty. It's not a simple profession where you can clump a paramedic and a nutritionist and a dietitian and rather then you want to address challenges and talk of improving services. If there are 5 professions that are under one umbrella, means you're only according 20% of that of their time to a profession that is simply overarching others, and it's important. So the challenge with that is it will then push EMS agendas down and not gain that prominence that it deserves. We need to have an organization that speaks specifically to pre-hospital medical activities, EMS activities. If we are to improve our services as a people, we need to give that profession the dignity that it deserves, because these are professionals, these are specialists. I know from your previous podcast, we've seen that even paramedics have an ability to conduct research, look at systems holistically, and improve how things go. Paramedics are not just, like I was saying, the job just belong to the ambulance. But that's what the general people think. They think that it's all about, turning on that siren and
Fast.
the lights. Then you drive very fast. That's an insult to the profession. There's more to people functioning as paramedics. We are there even before the disaster strikes or emergency strikes. We should be there from education, awareness, training, community programs that train to mitigate emergencies. If you teach, households how to prevent fires, how to respond to the burns, how to detect carbon monoxide poisoning, what you've done is you've saved an appliance from running across the city 10 times because you've prevented people from creating the emergencies in the first place. And that is the prerogative of paramedics, not just to respond, but to work in mitigating, prevention, and also once we do those first two things properly, response becomes a smaller component of our job, because there's no emergency to respond to. Most of them have been prevented, have been mitigated. But what we do is people then think we are all about driving very fast cars, bright lights, and
I mean,
which
it is cool, but yeah, it's no. I was just gonna say it is very cool, but definitely there is more to it, and I like that you are highlighting that. And I think in one of our podcasts we're speaking about social prescribing, which is sort of like what you're referring to as preventing these emergencies before they occur. Educating our communities. I want to take you back, right, to the time that you got to city of Harare. You have 5 ambulances. You are saving 3 million people with 5 ambulances. How do you do this? And how did you go about, sort of ensuring that you're running an efficient service when you are under-resourced?
So desperate times require you to be innovative and also the first thing that you have to do is to accept that I am under-resourced. I'm underfunded. But that doesn't change your mandate, your objectives to the residents. Your residents expect, even if you have 5 ambulances, to arrive when they call for help within 10 minutes in a 10-kilometer radius. That's what they want. That's what they've been told by their councillors. So what we did as a team, we had to understand how times have changed. Who is getting help where? How are we not duplicating our activities? Are we not competing only instead of complementing each other? So we then set up organization that was called ZEMSPA, Zimbabwe Emergency Practitioners Society, where we include everyone from private, public. We also then incorporated private players. And some private players were 10 ambulances. We then started to work together so that when we get a call, instead of just parking that call, waiting for one of those 5 ambulances to be available, we would simply relay it to a private player who is willing to take that call at the same rates. But if remember, we said we don't charge cash, but the cost for that service for City of Harare ambulances at that time was $20, which is about 400 rand. So for some other private players, they were willing, because there was no business at that time, so they're willing to go for that call for $20. And so we started to engage people who were like-minded, who were willing to offer a service, not get the premium, revenue or returns, but
Make profit.
also be part of the movement to try and impact positively with the little resources available. Because it's like you have 10 cows in a community, but you all want to plow all your fields. You can't just say, I have got one, so I can't plow other people's fields. You can combine those 10 cows and then you do the whole plowing. So that's what we tried to do. And at the same time, we also lobbied for resuscitation of the fleet replacement policies and adherence to such policies. But it's not just about formulating, it's also about adherence. It's also about approaching private entities, corporates, to support private entities to have what they call the social responsibility programs. So some of them bought ambulances 2 or 3 over, stretch of time, which then will be a shot in the arm. We also engaged communities, because if you know you've got little resources or ambulances, we look at who is calling for an ambulance. What are they calling for? Are some of those problems preventable? Are some of those problems, can they be mitigated? Can you train the communities to resuscitate someone whilst you are waiting for an ambulance to be available so that you don't lose that life. So there are programs like that where we are the community EMS awareness programs where we teach the residents that they're actually the first responders. If someone collapses, they should be able to do CPR whilst the ambulance is coming on its way, than to start wailing and panicking whilst what that person only needs is chest compression, buying time for the professionals to come. So once you create that awareness that we are all part of the same cog in terms of achieving EMS outcomes, you then also start to effect a change in the way people perceive your problems. So definitely that was one big problem that we struggled to improve, but we also found a way to collectively work together with private players who are willing to be paid less than what they usually get for a call. So that improved. Even before I left, we still had challenges with the size of our fleet, but we managed to mitigate or counter that by being innovative, creating awareness, training within communities. And I hope there will be scaling up of all those activities, because that's emergencies are not only when an ambulance needs to be dispatched. They can actually be mitigated, prevented. Then response becomes a small part of EMS. If you only then respond to the necessary ones, traffic accidents, obstructions in terms of other medical issues. But the majority of our calls, we found that we could mitigate them by community training, going into schools, teaching how to respond to fires, how to resuscitate each other, all those things. So because of challenges, you don't just stop there and wait for a politician to approve your budget. No, you become innovative. You work with what you have. If life throws you lemons, you make lemonade, and you can't just stop there.
That is
Like
very
what you
true.
said. Yeah. Sorry, Elias, can I quickly go there? So, there's a model, it's about Kubler-Ross model that deals with grief. I'm sure all of us know it, where you go through stages, denial, anger, bargaining, depression.
Yeah.
And the last step, I think it is more on towards acceptance, where you reach the point of no understand of understanding, and you acknowledge that reality has happened, from 40 something ambulance to about 5. That's a huge. And the last stage of acceptance is more like there's nothing that you can do. You've given up rather than accepting what has happened, and you learn to live with it. But what I like about the story that you've told us is that although you've accepted that, okay, this is what we're dealing with, but how do you address the challenges to make sure that there is service delivery for emergency service delivery of emergency medical services to the community? And the thing is, the work that you've done is commendable, because for an emergency physician, you said you're a medical doctor. You're not even someone who's emergency medical services, but to have an impact on the emergency medical services, you have an understanding why emergency medical services forms a part of an important essential service for the whole community. And that is good. I mean, working with those stakeholders to ensure that they provide services, to have people working just for a little minimum so that they can service the community. What I do want to ask you, though, is that despite having those resources, getting those ambulances that you're getting, in terms of staffing of ambulance services, I know in certain aspects you said there might be nurses. I think in the mission hospital, mission ambulance services. When you try to revive the emergency medical services in Zimbabwe, what was the staffing look like in terms of was it who were the ambulance technicians? Was it ambulance technicians who were staffing the ambulance services? And also, just to add to that question, in terms of equipment, did they have? You can have an ambulance, but did also have the necessary equipment to actually provide the treatment that is needed to the
EMS
patient.
services.
And I think it's Harare, isn't it? Not Zimbabwe as a whole.
Harare.
It's Harare specifically for the city.
So,
okay.
So what we are talking about right now is specific to the geographical place that you call Harare.
Yeah.
The population of 3 million, but that is the capital city. So obviously the population changes during the day and it recedes during the night. So coming back to what you have asked, it's quite pertinent. You can't have a vibrant EMS system without the necessary HR. You understand? So because there are various models of EMS, some are hospital-based. You then find that in the hospital-based EMS systems, EMS ambulance system, because of the government structure, they don't have a position of an AT or EMT. So those ambulances were basically manned by nurses. If it's a hospital that is in the district, there's no structure or position for an AT, EMT, or paramedic. So those ambulances, when they are conveying patients from this hospital to central hospital, those patients are being looked after by a nurse. So what has been happening now, there's been lobbying from various EMS players, be they private, be they local authority or public. So what we have done as a team is there's been constant lobbying of recognition of those titles, AT, EMT, paramedics as professions, as professionals that deserve recognition, that even if it's an hospital-based EMS system, there should be ATs, EMTs, or paramedics. If they can get the nurses to appreciate the training for AT and EMTs, then that would also then you can kill two birds with one stone. So what has been happening of late, we've seen an influx of nurses, registered general nurses or state certified nurses. We have appreciated the AT training, EMT training, and some have even gone to do ACLS, or some have gone to do postgrad studies in EMS. So there's been a paradigm shift where you're now having nurses appreciating the EMS training curriculum, because the nursing curriculum doesn't train or prepare someone to function outside the hospital. But you see that the protocols that they learn within hospitals, they actually archaic when you put them in the bush, where they're not protected by those four walls. So the EMS training makes someone adaptable. Whether you are in a hospital, you can still be of service, can still be of use, but you show your true worth when you don't have the comfort of hospital beds, ventilators, theaters, where you have to save a life in a confined space, under the mercy of the elements and all those things. So that's the first part. The second part is, as far as staffing was concerned within City of Harare, we were blessed in that regard because we were running a training school. So we would train people from the basic AT, ambulance technician. They would then practice after qualification for over 1,000 hours. That is recorded, supervised, with procedures witnessed or signed against. Then after 1,000 hours or 2 years of working, they'll be eligible to then enroll for EMT. So EMT was more like, we tried to make it robust, more comprehensive. At one point, we shared our curriculum with a London university and a South African school. I think it was UJ or something. Then they told us that what we're teaching is too much for title of EMT. Why don't you introduce paramedic? So now, when I left, they were working on introducing the paramedic school. So in terms of HR, I had at my disposal over 200 ATs and EMTs combined. So we were not understaffed, but we were, in terms of vehicles, we couldn't service those 200 people because 5 vehicles with 200 ATs or EMTs, that was like a mismatch. So that's why we started to have those are functioning without vehicles, to go now into the community to teach, schools to teach, because we had that resource. So we had to be creative around how can we still save lives without necessarily having to speed in the tarmacs, but to give the same information, prevent. If you know how to prevent an emergency, you've saved resources, you've saved downtime, you've saved money, you've saved the risk, people, paramedics from having the risk to traverse against in these busy roads, driving at tremendous speeds. So it's a lot of positive if you then use what is available to you efficiently. But it starts from you accepting that this is what I have. What can I do with what I have? How far can we go with what we have?
Yeah.
So
I wanted to say,
Yeah. No, you can go ahead.
sorry to cut to someone. I was thinking that if the Pan-African in me says that if you look at 1984 until 2012, I mean, 1984, I think Uncle Robert, he started, I think, 81. He was the president and things changed. And you mentioned that Harare was actually doing great at that time, greater than it did later. I mean, having 46 ambulances in the city of Harare was something great. I think a lot of African countries didn't have that. A lot of African countries didn't have a functional ambulance systems. Others still don't have now. So he had a very good foresight. I'm not sure whether it was him, but there was something good that was happening that he was doing at that time. And then the time that you took over, 2012 to 22, it's 10 years and it's the toughest period. I think people that are not from sub-Saharan Africa may not appreciate the hardship that Zimbabwe faced there, the sanctions from the West, just killing the economy, high inflation, high migration, people feeling that they can't live in the country, change in usage of the currency because the Zimbabwe currency wasn't functioning. It was just a tough position. So I do commend you for the period of time that you were in charge and the mitigating strategies that you had. My question, though, it will be, in terms of training, I understand that you were involved in the training of the clinicians at the time. Has there been any appetite in formalizing the education, like having a diploma or a degree in EMT, like the paramedicine becoming a degree? Has there been a appetite to do that? That's one. And then is, in terms of the allied health workers, the Council of Zimbabwe, do they disseminate the guidelines to the practitioners, or the practitioners decide based on the training that they received from their institutions? So those are two questions. Is the appetite for formalization? And the second one would be the guidelines. Who decide on the guidelines?
yes, those are very valid questions. So what I'll answer your question in two parts. The first one about appetite. The appetite is there. There have been 2 universities that have started rolling out an equivalent of AT coming out as a diploma. They call it EMC, I think. I've not had the time to.
It's okay.
To be either to be invited to look at the program or to see if it applies to. Because I don't know who's teaching the course, and so I didn't have time to look at their curriculum. It came out around during the COVID time. Then there's also the talk of the current training schools to roll out paramedics as a formalized course. Then there's also a talk of introducing another diploma to equip our medics so that they become competitive, so that they become internationally recognized in terms of qualifications, but in terms of outputs. I'm sure you're in Middle East, right?
Tulan is
I'm in the Middle East.
Yes. There's a very big Zimbabwean community that has come either as paramedics or firefighters. Our firefighters actually they're being recruited left and right center, Dubai, Saudi Arabia, and Qatar. They are living in droves. And what they're actually asking for is, have you been trained with City of Harare? If you just produce a certificate that you've done your training, you've worked in the City of Harare, they quickly snatch you. If you present certificates from the private players, you will have to come and be assessed with City of Harare to see if you. So what I can say is, it's not just a question of introducing new programs. It's a question of holistically looking at the current curriculum and see what is working, and also see what is no longer relevant to the current dictates. Because if this curriculum was designed 20 years ago, surely there are things that would have lost relevance because of times have changed. Medical issues improve from every 3 months to 6 months, a year. Things change. So if you have a system where you evaluate and validate whether your program is still relevant to that particular population, then it will be okay. But if you want to create a cadre who is balanced, whether they go and perform very well in South Africa, in Kenya, in UK, then you have also to look and be ready to accept if someone says your curriculum may need tweaking here and there, or may need to be improved here and there. But if your training is speaking positively to the demands of that particular population, then it will be okay. But if we're saying we want to move with the world, then we have to look at ourselves, at our systems objectively, and say, okay, definitely, if we want to move with the world, but we also need to understand where the world is going, or for what populations are they talking about, or what are the needs of those specific populations. We hardly have snow in Harare, but I know Johannesburg, we've had blessings of snow here and there. There are injuries that are creating emergencies in UK. Naturally, as South Africans, your curriculum in the EMS sector should cover snow-related injuries. We're talking of other things. People crashing during blizzards, and how to drive during such conditions, and how to extricate people in such harsh conditions. If it can happen in Johannesburg, in Lesotho, in the mountainous area, definitely we need to accept and adopt things that will benefit us. But in other parts of the world, you find that you can then train someone to have a skill that they may never impact or use in that particular population. So I'm a bit flexible with in my approach to that. I will accept anything that will make our medics competitive within Zimbabwe. And obviously, I know this world is now like a global village, so people are moving. They also need to be competitive out there. So naturally, we need to move with the times.
Sure.
Sorry,
Thanks for that.
Tulani.
Yeah.
Sorry,
Oh, you wanna go? Yeah.
just because of time. We're gonna have to sort of like, cause we are just approaching an hour now. We're already on an hour. I think if you can just paint the picture for us. Obviously, the time that you got to city of Harare, 5 ambulances. What is emergency sort of like response like now in Harare as a city as a whole? Not just from the city side of things, but also from the other role players. Are things changing? If I call for an emergency today, how long do I have to wait? Like I know in Ventuk, I probably have to wait for at least 15 to 20 minutes before an ambulance can arrive. It eventually arrives, but it just might not arrive in within 10 minutes or, 5. Sometimes it does, depending on where you live. But yeah. And also, if you can maybe just touch on, is there one single number that I can call in Harare and an ambulance will be at my doorstep? Or how does the system go? If you can maybe just touch on those just because of time, and then we round off, please.
So I will naturally be honest in terms of what has probably happened after I left, because it's now from 2022 to 2025.
3 years
What I
later.
know is, by the time that I was the ambulance service director there, we didn't have a single functional number. It was there, but I've added functional. The number was there, but the challenge was operationalizing it. It appeared there was a challenge. But at the end of 2020, 2021, our telecommunication parastatal player, together with the Minister of Health and Minister of Transport and other security people, they came together. We were part of that meeting where a number, where a quadra was created dedicated to emergencies with one centralized call center that would act as a dispatch center, and then it will then redistribute the calls depending on the need, on the emergency, and also in terms of availability of the appliances. And so, yes, there's a number and activities that have been done to have that one thing number, because it makes it easy for someone, whether you are asleep, you can just wake up and dial that number, because it's easy to remember and it's centralized. But unlike to then claim a 7-digit emergency number, it's difficult to activate EMS. So there have been improvements. For example, the government recently procured 32 helicopters for EMS from Russia. And in as much as people see things differently, being an EMS invested person, it was a shot in the right arm. Obviously, if those helicopters are deployed efficiently, responsibly, and equitably, they'll also improve the response time in terms of people who would have had accidents far away from centers of definitive care. My challenge is always about investing in EMS when systems are not synchronized. What are we trying to achieve in the broader scheme of things? Because I definitely love air rescue and air EMS, but I would start by maybe, instead of procuring 10 helicopters, you would then take that money for 10 helicopters, you buy 500 ground ambulances so that they complement the air. Because the air rescue, it's important. But the majority of people need ground EMS equipment. So this is happening positive, and I think the reason is, I think we didn't push enough to lobby to have a director of EMS within the Ministry of Health, so that they will help with, creation of the right policies that will then speak to the decision makers. So I would say something positive has been happening, and many private players are coming on board. My challenge is how they're going to be financed. Are we going to have a fund that is created that will cater for every resident? If a private player responds to a call from someone who can't afford, are there a mechanism for that private player to be compensated for that service? Because they're there for business. We have to be honest. If we can't, then we also need to recapitalize and resource mobilize to equip the public EMS system. Those are local authorities. Already they've been working well, working under difficult conditions, saving lives. How much? That's why we did that research, to understand what's happening, to understand who is getting help from which part of the city, what are the main complaints, what are the response times, what are the needs. So the response time can actually vary. It varies from being very good to 10 minutes in a 10-kilometer radius. But it has to be objective. You can't say 10 minutes in, because you can respond 10 minutes in 2 kilometers. That's not good. But if it's 10 minutes in a 10-kilometer radius, you're now speaking of international standards and best practices. So in a 10-kilometer radius, it can vary from that 10 minutes or less, or it can actually be longer. It can be 30, 40 minutes, sometimes 2 hours if those 5 appliances are busy. But from the time that appliance is then dispatched towards that particular call, because now we only speak of response time when an appliance is dispatched towards that particular call. But before that, there's what we call call waiting time. So what we're talking about is the call waiting time can actually be longer, to around an hour to 2 hours before an ambulance is dispatched towards someone who's waiting for that ambulance. So there are two things. Call waiting times can be longer, but once that ambulance is dispatched to that particular individual in need of help, we've seen that our response time taken for that appliance to be dispatched from the either the last call or from the by the control from the station to the patient, it's been quite encouraging despite our few numbers. But what I'll admit are the long call waiting times, where you call, say, I need an ambulance, I'm in labor. Sorry, we don't have an ambulance right now. Can we direct your call to a cash paying ambulance? I don't have money. I'm willing to wait for your next available appliance. Okay, we book it. Then once that appliance is available, that waiting time can vary between 2 minutes to 2 hours. But once that ambulance is dispatched, once it's available, we then prioritize, because we have to triage the calls, we then prioritize the one that will still benefit, that needs it at the earliest possible time. The response time is still between 10 minutes in a 10-kilometer radius to 30 minutes in a 10-kilometer radius.
Sure. Thanks for that, Doctor. Look, I quickly searched for the degree EMC in Zimbabwe, and I found that there's a women's university of Harare that teaches. They've got the diploma, and also they've got the degree in emergency medical care. But also what I saw with the diploma is that the degree is 3 years instead of 4 years, which is quite different from what we're offering. Probably it might be similar to what Namibia is offering. What I do want to ask you is that which brings us, you mentioned research in the last part of your discussion that you've made now, is that, and you mentioned that that's why you did research. What is the current state of research, pre-hospital research in Zimbabwe, especially in the pre-hospital setting or involving emergency medical care?
That one is it's. I think our research is not alive. It's in ICU. If I can use that.
At least there's a ventilator.
Why I say
Let's
that
say
is
it's in infancy stages, maybe.
Yeah, the issue is, the challenge is, for me, the way I looked at it is I spent 10 years heading an ambulance service. We were generating a lot of data, outcomes, but we only managed to do to start the first research in 2019. I'm looking at what I did during my time at the city. When I look back, I'm not happy with what happened during my time as the head of the EMS. We could have done more. We could have published retrospective outcomes research once a year, even once every 2 years. We could have created a trend. So this is not to point fingers and say he did what, she did not do what. I'm looking at myself through a microscope, looking at my time. Say, did I do justice to my salary, to my resources? Though there were few. What did I do with those few resources? Did I publish? Did I even write any research to talk about how underfunded the EMS system is? I didn't. So how can we objectively look at such systems to improve when you're not creating scientifically based baselines? So that's why I'm saying, if it takes our EMS for city of Harare from 1984 to 2019, maybe to have 2 papers. The other one was, I think it was just a survey, which was done by Dr. Thompson, but the actual research that was done with support from our American colleagues, that's only one. Yet we generate tons and tons of information. So we're talking for retrospective research, outcomes research. We're talking of prospective nothing. We have huge gaps there. We have done more. We can do more, definitely. I can't speak for the private sector because maybe I'm only informed with what I was doing. So as a city, obviously, we work with city health. If you look at city health, which is another department, they publish almost every year. TB research, HIV research, typhoid research, cholera research. But we had EMS people participating in cholera, manning the tents, assessing the clients. We didn't write even a research about the role of EMS or medics in cholera. Cholera is a pre-hospital disaster. People are treated in the community, in cholera tents. That's pre-hospital. Especially setting up a camp in the bush, you're taking people from their households, bringing them. That's a pre-hospital issue. But we didn't write yet. We had people going into those tents, into community, conveying cholera cases to those tents. So definitely we have huge gaps there. The only study we did there, I don't think we deserve to pat ourselves on the back and say we did something. There's more that needs to be done. If we were to speak the truth and be Africans, and if we want to develop, we should say we didn't do well when We can't celebrate one research. There's need to do more. There's need to do more. Or 2, 3 a year, or even one paper every 2 years. That speaks about EMS in Zimbabwe, in Harare. We can do that. Because the data is there. We just need to train our ATs as part of their initial training, the importance of looking at what you're generating and making a story out of it. If it can be then, then becomes a culture, then it's easy to say we now have a culture of research, publish. When we speak to our decision makers, we are not talking out of emotions. We are talking of research findings. You can't argue with a scientifically based paper that is based on proper eminence. What we need is to not to say, why are you killing your people? What are you saying? We need to tell the decision makers that we have longer response times. We have longer waiting period times. But if we have 10 ambulances, we might cut it by half. Because when they look at research, everyone wants to sound educated. Politicians are getting PhDs, whether honorary or what, but they all want to sound educated. So you use that, what they want to be. We give them proper researched issues, not out of motion. So research has to be a culture in our setup. And I'm sorry to disappoint you guys in saying I would want you to say, well done for publishing. I didn't do enough. We could have done more. And there's still room for more.
Yeah, no, I think
just one
had
more
you not
thing,
done that one specific paper that you have done, I don't think would have gone through to you. But thank you for publishing that one paper. Yes, Tulani, you had something to say.
No, I was gonna say something similar to that. That if it wasn't for that one paper, I think there's more to be done. But also with what you've said is that it makes me to be worried because we're not. This is the third time we're discussing in a podcast where we're saying there's not a lot of research that is being put out there, especially in the African context. There's not a lot that is pushing, as emergency medical services in Africa. Whereas when you get in the Western world, there's a lot of research that is coming from that side. Yeah, that's it from my side, Elias.
Yeah,
but my challenge
I think I was just sorry, just because of time. Yeah, we're just gonna do another second segment, so maybe we can chat about that in the second segment. Sorry, just because you've gone over an hour and 15 minutes now, we're cutting into another time. So I was just gonna say, Dr. Soman, thank you so much for being so informative. Thank you for enlightening us and basically just sharing a lot of light around what happened in Zimbabwe, what's happening in Zimbabwe, for us to get an idea. Because in all honesty, until today, we had no idea of what's happening in Zimbabwe. That's why we are trying to push for these communities. Hopefully that we can make communities out of these podcasts so that we have a point of reference in each country that we can say, yes, exactly according to, this is what is happening. And at least we have some form of reference. We do agree that, and we are trying to push as a community for research and in other conversations, it has come about, we have been having paramedics in the southern region, to be specific, for years and years, but the amount of research does not equate to, what we are doing. And a lot of people don't know what we're doing. So thank you for all the information and, everything else, your time. And we appreciate you for coming on to the podcast. For everyone else, please do like and subscribe. Do share it with everyone else that's within your community. That's how we reach different individuals. We are just approaching 300 subscribers, a community of EMS-based people and others. So we do appreciate and we are planning to expand. We do want to reach out to other countries. So if you are in a country where there is EMS, the likes of Angola, the likes of Mozambique, and the rest, and you're a paramedic, please reach out to us. We would like to chat to you about what EMS is like in your country. And we would like to know, do you have an ambulance? Do you have 5? Do you have 43 ambulances? Yeah, let us know. Thank you very much. This is the end of the show, and goodbye.